So we've had quite a range. I hope that people will send in, continue to send in questions. While we're waiting for people to get their thoughts together, I'm going to ask each of you to give one summary statement or recommendation after hearing all that you've heard this morning. So I'll do the order that we went in. Kevin?
Yeah, I appreciate all the insights and great content of the other panelists' presentations. I mean, this is the challenge we're in, right? That I think has become very clear with these presentations and the other ones earlier today is, we're unhappy with the current state of measuring access, and often with access as it's performed, or how accessible care is for veterans in the system. And yet it's really challenging to say, how could we do this better? And how do we do this without making it so complicated and coming up with so many measures that it just is self-defeating? How do we be careful that we seize on one measure like wait time and there's going to be just what Martin talked about with all these unintended consequences if you put all your emphasis on one measure and that's where your interventions are going to go. You can drive that, particularly when there's a lot of political pressure or there's incentives linked to that, at great risk that there's going to be some countervailing issue that actually gets worse because you're not, neglecting other things that need to be tended to. So I think the challenge for this workshop is how to come out of this with something in the middle where it's not an oversimplified reliance on just one or two measures. It's not more complicated than it needs to be, or complexity is targeted to where it may be applied, as I was saying, at the front line, where we really need a more complicated or complex, multidimensional way of understanding how is telehealth playing out or urgent care access playing out, and a bunch of measures to really do a deep dive there. So it's finding some sort of balance in all of this. And I think absolutely to be aware that there's trade-offs to everything we do. And I think the final thing I just wanted to emphasize I do think the more global the measures can be, the better for overall tracking again. And I think it's really critical to distinguish that. The SHEP survey is a really interesting example where it has very specific access questions to veterans about how is access for urgent care, how is access for after hours care. It actually doesn't have the global sense of just overall, how easy is it for you to get care in the VA when you need it. And personally, I would tend to use more of those global ones for the sort of overall performance and tracking and say, I don't care whether it's through telehealth or urgent care. In general, vets are feeling like when they need care, they can get it. That's a pretty good global measure, along with wait times and some other things. But if we're really then going to, use some of the other SHEP question items, they would be more for the local improvement activity targeted to that specific question. So I think having this balance between some global measures and then some more detailed ones that are used for more operational purposes. And along with what Pat said, all of this aligned with things that we think actually do make a difference for the health of people.
Thank you. Mary.
Well, I think that we are on the threshold of an electronic revolution, and that there will be ways to collect data that is less burdensome to the delivery system, and that we should consider how access is a part of that, how access can be wrapped into metadata that is provided, through the EHR to the payer or to other, entities that are going to use that information to provide feedback and measurement.
Thank you. Okay, Patrick.
I will pass now because I'm eager to hear the questions from the audience. I don't have anything to add to what Kevin and Mary have said.
Okay, sounds good. Martin, do you have a comment or no?
Yeah, I really like the distinction that has been made between measures that global measures that might be used at a high level and different types of measures which might be used locally. And we have in England a completely useless test called the Friends and Family Test. And I don't know if you have that in the US, but it basically says it's a single question asked to all patients when they leave hospital. Would you recommend this facility to your friends and family? And I think it is widely agreed that this is more or less completely useless. However, there's a box below that says, is there anything that you think they could improve? And that is the one that quality managers in hospital like, because it has actionable things. So if it says the toys in the pediatric outpatient facility need cleaning, you can go and clean them.
Thanks. That's great. Okay, we have a question. How do we reach the goal, if we agree, of finding measures of access that improve quality of care and improve outcomes overall and by disparities? I think maybe we touched on that a minute ago with actually both Kevin and Mary.
Well, and I think Patrick said that no measure is the end of time.
Yes.
We measure something once and then we look to see how we can improve it and what we need to, how we need to raise the bar over time.
Okay.
Right. And ultimately, it requires, as much as we may hate to admit it, it requires a portfolio of measures. Some of those measures may be geared more towards veterans, towards consumers who are choosing where to go for their care. Others may be geared more towards policymakers. Others may be geared towards managers or providers. But there's no getting around the need for a portfolio of measures to capture the range of concepts.
Great. Yeah. That, and you use the word portfolio. It seems like we're all of the speakers and some of the questioners are basically saying it's going to have to be a portfolio, and how you structure that and who you provide measures to is going to be really important. We have another question. What does Martin suggest as far as getting VAs elected overseers to better understand the complexities of access? Oh boy.
It's I'm tempted to say it's absolutely hopeless. I mean, politicians always want simple things. They want simple solutions. They want things they can claim have been delivered quickly. I do not have an answer to that. They hate complexity. It's one of the reasons they don't like academics, because we complicate things. So I am not looking forward to my meeting with your president to explain to him how to improve the VA healthcare. I just don't think it'll go well.
You never know. Somebody, let's see, Kevin, I think.
Well, I mean, Lisa, I totally agree with Martin. But with a little nuance, Martin, I guess to say that I think we in academia then sometimes overly complicate things. And I think this is the challenge, is how we don't get so lost in the measurement world and come up with, just endless new measures and 52 different conceptual frameworks, because then that just undermines our ability to put forward a pragmatic, data set and say, these are really the ones that you should focus on. And it's still maybe too complicated when people want, it's the wait times, damn it. And that's what every testimony on the Hill is going to be about, is why did that veteran in, Colorado have to wait, 6 weeks to get the gastroenterology appointment or something like that. But so those politics will always be there. But I think we need to keep pushing ourselves to understand the end users for this work and be able to deliver something that has practical application. And I think that's understanding it's a different audience on, the White House or Capitol Hill than your local practice manager who is interested in cleaning the toys in the ambulatory children's unit.
So it kind of goes again to the idea that measures need to be of different purposes. And the same kind of thing might not work for Congress. Does anyone else have a thought on that intersection with politicians?
There was another question, Lisa, about, the UK experience, which this whole idea about measures and having a monetary incentive attached to them. And I think that's worth addressing a bit more, because Patrick had such an eloquent, appeal for measures should be used as tools for improvement. That's what we're not. They're not scorecards, or not, to judge people who's doing a good job, who's bad. And particularly when you start attaching payment incentives, either to individual clinicians or practice units or regional units, or there's big consequences. I mean, Patrick, I'd almost address you. I mean, it seems that starts to undermine the ability and confidence and sort of culture of using these measures as ways to everybody buys into improved care. I mean, do you see there's that there's tension there when you load too much financial consequences on these measures? I'm maybe being unfair and calling you out, Patrick, to see if you have an opinion about it.
Well, yes. I mean, there's no question that there's tension. I'm eager to hear Martin's thoughts from the UK perspective as well. I mean, I will say that putting some money on the line gets people's attention in a way that can be hard to get otherwise. So having a little money on the line is helpful. Having too much money on the line is counterproductive. And how do you set the right amount is very tricky. So I'm not sure what's the UK's perspective. Do you have the answer for us from the UK?
Well, I think the first thing to remember is that the key thing that drives high quality healthcare is that we have highly trained professionals who have a high degree of internal motivation to deliver good care. And we spend a lot of time training our physicians and other healthcare workers, and etc. So the concern is that if you apply strong external stimuli, either penalties or rewards, that you may reduce the internal motivation of physicians and potentially reduce the professionalism with which they go to work. So they go to work just to tick the boxes they've been asked to tick, instead of doing what they truly believe is a good job. And that has been something that's been quite extensively discussed in the literature, and I think is a risk. And it's a particular risk in one situation. It's a risk if the things that you are asking the physicians to do are not things that they fundamentally believe as professionals they ought to be doing. And our experience of that in our paper for the performance scheme is that when we started off, the things that were incentivized were things that they were the low-hanging fruit. They were things that, broadly speaking, physicians thought they should be doing anyway, probably were probably trying quite hard to do, and didn't mind a bit of extra encouragement. Subsequently, government brought in incentives, particularly around hospital admissions, that actually had nothing to do with what physicians thought they should be doing. And then that brought the whole scheme into not exactly disrepute, but I think trying to align the things that you're measuring with things that physicians truly believe they want to do is really important.
Thank you. That's great. And we've got some more questions here. One saying, I haven't heard any discussion regarding who provides the care. In a day of multiple levels of competency, being able to be seen on the day by the most junior, least trained team member may result in more visits. ... Does somebody want to answer that one?
Well, I'm glad to say that it seems to me that it's more an issue of being able to see someone, to be able to see the person who you need to see and who can handle that interaction with the most efficiency. And it's not always the doctor, but I don't think that we should be saying that seeing a junior, least trained team member is necessarily going to result in more visits. I don't think it's quite fair.
But I think it gets at, these unintended consequences where if there's such pressure around these things like, okay, the wait time needs to be moved down, it may be, okay, one way to do that is schedule more appointments with people who weren't really the person preferred by the, the patient to be seen, or you pull in personnel to do that who may not be the right personnel. You know, you hire some extenders or what have you, or you know. So I think I put that into the unintended consequences. Is it access to the right person at the right time for the right care? Sort of how Yee's framework of is it precision access, or are we just sort of, you know, to be able to check that box, you know, coming up with a delivery model of care that's actually not going to get patients what they really want and what they need?
Yeah.
I think there are two implications of this, you know, very important question. So one is to recognize that we are increasingly functioning as teams, and therefore it's appropriate for us to be held accountable as a team. And so it doesn't make sense for individual physicians, for example, to be rewarded or penalized, typically because we're dependent on the entire team that we work with. However, we also have to recognize that it's human nature to find the easiest way to fix a problem. And if the problem is that the box isn't getting ticked enough, then what's the easiest way to get the box ticked more? And so that may involve hiring a relatively low-paid person who can't really do anything but tick boxes. And so that person makes sure the boxes get ticked, but in fact, the care of the patient's outcomes have not improved. So we have to be always anticipating, as Martin suggested, how are people going to respond to this measure? What's the easiest way for people to solve this problem? And figure that's what they're going to do. And then we have to either design our measure to be robust or figure out a balancing measure to catch that.
Very good. We have another question. Perhaps someone could respond on what are the professional motivators, incentives to get providers more involved in designing care processes in a way that will design in more timely access. That's a tough one. Anybody want to take a go at that?
As I say, I mean, we are in the world of user-centered design, and I'll flash back to, I think, Adrian Adezato, it is at the early session, who brought the veterans perspective, and then Hal Yee really talked about this interplay between, let's say, a specialist and the referring primary care clinician to kind of determine what they think would be the appropriate timing and need for an in-person, or could it be handled like a virtual consult? So it seems to me you do want the end users, which is a combination of patient and community stakeholders, the frontline clinicians who are part of the design team. When you identify some things that you're measuring, you say there's a need for improvement, that you actually go to those users and make sure they are part of a participatory process. I think when you try to do this stuff, a bunch of executives and managers, or particularly the further they are from the actual practice unit, the less likely they are to really come up with solutions that work for that particular context, which means that it may not be one size fits all. So that's why the access sort of intervention package in one region of the VA may not be the same as another, because that whole context may be very different. That the more you involve the users, the end users, both the deliverers of the care, people receiving care and participating in their own care, the more likely you are to come up with solutions that work.
Yeah, I think there's a way to view that in terms of what people have said about sort of large-scale measures and what their characteristics should be, and smaller scale measures that would be used for improvement. Because I think a quick positive and negative example, the negative example was VA mental health care initial measures, which didn't work in a way that matched what people could gather at their own sites. So they basically didn't believe them, and they just got rid of them because they didn't translate into daily life. And on the other hand, the measures of continuity matched more detailed measures of continuity at the site level, and people then could they could find out about the individual clinician or whatever, the individual patient that wasn't in continuity, and figure out solutions. So I think clinicians are motivated to improve if you give them half a chance. And half a chance is giving them access to measures that they can make use of in their local environment, and at the same time use the larger measures for big picture questions and improvement targets. Any other?
Well said, Lisa.
Yeah, we have another one. What performance measures and indicators exist now for VA on a national, regional, and local level in terms of timely access to care? I think, does anybody have a thought on that? Is that Patrick getting ready to talk or no? I could say something about that if others don't, having lived longer in the VA.
Please do. You're
Some of
immersed into it, yeah.
I think there are a large number of measures, and there is increasing desire to integrate patient perspectives and to do it in a way such as what Mary suggested, that can be as much as possible informed by data. An example being, and this is from a conversation I had with some of the people from Dr. Kirsch's office. They're becoming more sophisticated about letting patients choose an appointment time and registering that they chose a time that wasn't the same, and getting clerks to answer accurately in that regard. And there's also the waiting list that's getting more sophisticated and is trying to figure out how to integrate sort of need for care and preferences for care into the wait list decision. And I think that's still in evolution. To get more detail than I've given, I think you need to go to Susan Kirsch's office, where they are definitely thinking about these issues and trying to figure out feasible ways to make them happen.
Lisa, this is Ken. I was just going to suggest that perhaps we carve out a couple of minutes tomorrow to answer that, as well as a couple of other questions that came up that we could provide more thoughtful answers then.
That sounds like a great idea. But I think if anybody on the panel wants to suggest something as a priority, now would be the time to do it. Does anyone, well, maybe I'll go around and ask if you had one succinct measure that you would put a priority on including, what would it be? I think you've already said some of it, but just saying it in a targeted way. Kevin?
My vote would be a patient-reported global measure of can you get care when you need it.
Sounds good. Mary?
I second Kevin's nomination.
Patrick?
I'm still fond of outcome-related measures that look at potentially avoidable utilization or relate potentially avoidable utilization to lack of control of chronic conditions.
Martin?
I'm interested in patient choice and choice, which is often the case for continuity. So whatever the question is, I would include the phrase, the doctor you want to see.
Very good.
But Lisa, could I piggyback on
Please.
the question there? because, and this is something that has come up over the past few months as we've been looking at this question, is where would the panel place measures that looked at things like how much did they seem to care about me? How much did I trust the input that was being given? Things that are, you know, pretty soft and mushy and hard to quantify, but seemingly have an awful lot to do with how people feel about the care experience.
So something about trust and those kinds of things.
You know, Ken, I think it's a slippery slope you're going in, because you're really then going deep into the whole patient experience domain, which has so many multiple elements to it. And I think
absolutely agree.
Which is important to, I mean, again, that may be worth measuring. I'm not sure I'd put that in the access per se. Again, they blend together, as we say, quality access, patient experience. But yeah.
I think the point that Ken is perhaps making is that, sure, trust and empathy isn't part of access, but might be more important, because I guess there are more patients who would much prefer to wait 5 days for someone they trusted and could get on with than see somebody else tomorrow.
Yes, exactly.
And which is directly relevant to VA spends many billions of dollars every year in pushing people out to the community or trying to keep them within the system where they know their providers.
Yeah.
I mean, it's a directly relevant question to how VA approaches this problem.
Right. Which is all the unintended consequences. Oh, that may solve, quote, the access problem, right? Oh, they can, and sometimes we don't even know, though, as has been pointed out, is that really going to be more timely? But it's, oh, information flow doesn't then happen back to the rest of their care team within the VA, or where they're getting their specialty care now, or their primary care. So it fragments care. It may be that there's less continuity, there's less trust. So you have to, I think that's why holistically, and not, if you put all your money on that access measure and not measuring all those other parts of what we think are important for great healthcare, you wind up in trouble, I think.
So you're arguing for seeing it as a package with other elements of healthcare, and it's probably an analytic issue how you might combine those things, but to try to keep the access part focused on being able to get the care that you, I forget exactly how you said it. You said it very well.
Or it's that unintended or sometimes even intended or easily anticipatable consequences where it diminishes some other important aspect of healthcare that makes for holistically great care, which is more than the sum of each of those parts.
Okay, I think that's a good note to end on. Does anybody have a last word that they want to say before we wrap up? If not, thank you so much to the panelists and the questioners, and we'll turn it back over to Emily.